as a digital partner for this event, and the today's focus of today's session is labor pain relief. Now, I would like to invite Dr. Meenakshi sundaram, sir, a distinguished anesthesiologist and academic leader. Sir has served as a dean and a DME at several government medical colleges, including Theni and Stanley Medical College, Chennai. He is former national vice president of Indian Society of Anesthesiologists and has held key positions including governing council member, president, and state secretary of ISA Tamil Nadu State Branch. To proceed with the session, over to you, sir.
Thank you very much. At the outset, I request our President, Dr. Munian, to offer his presidential address.
Good evening, all. On behalf of ISA Pudukkottai City Branch, I welcome moderator and the speakers and the delegates for our online webinar. We are conducting every week in the name of Puthukkottai Bhudhan. Today we are conducting 19th episode of second edition on the topic of labor pain relief. I am honored to honor the guest. Today we are going to discuss about the maternal care and labor pain relief. As a healthcare professional, we have come a long way in understanding the complexities of labor pain and the developing effective methods of pain management. History of labor pain relief. The use of labor anesthesia for childbirth dates back to the 19th century when James Young Simpson first administered the diethyl ether to a woman in labor in 1847. The pioneering work paved the way for modern anesthesia, modern obstetric anesthesia. Simpson's innovation was met with a resistance, but public demand eventually led to its widespread adoption. What are the key considerations in labor pain relief? Pain perceptions. Labor pain is a complex phenomenon influenced by the physical, emotional, and psychological factors. Anesthesia options, various anesthesia options are available, including epidural anesthesia, natural childbirths, and pharmacological interventions. Maternal and fetal well-being, ensuring the safe and well-being of both mother and baby is a paramount when selecting pain relief options. What are the effective pain relief methods are available? We are mostly advised epidural anesthesia, which is a popular and effective method of pain relief during labor anesthesia, involves injecting anesthetic medications into the epidural space. Next one is natural childbirth methods. Techniques like breathing exercise, massage, and hydrotherapy can help women cope with labor pain relief. Pharmacological interventions. Opiates and other medication can be used to manage labor pain, but their use require careful considerations for potential risk for both mother and babies. Conclusions. Labor pain relief is a vital aspect of maternal care, and healthcare professionals must stay updated on the latest techniques and research to provide optimal care. By understanding the complexities of labor pain and offering a range of pain relief options, we can improve the childbirth experience for women and their families. Today, we are gathering for online webinar. Our speakers are interested to share their experience with all of us. Once again, welcome all. Let's listen to the webinar. Thank you, sir.
Thanks, Mr. President. Now I request our branch secretary, Dr. Kannan, to offer his secretarial address.
Good evening, all. I am Dr. Kannan, Secretary, ISA Pudukkottai City Branch. Successfully, we are conducting 19th webinar of second edition of Puthukkottai Bhudhan today. Welcome all eminent speakers to the webinar today. Last week, 21st May, we have conducted 18th webinar of Pudukkottai Bhudhan successfully. Last week, our topic was inotropic support. We have divided the topic into 3 subtopics. First one is factors affecting cardiac output. Second one is pharmacological inotropic support. Third one is mechanical circulatory support. Our moderator was Dr. Muralidhar Kanchi, Director, Senior Consultant and Professor, Narayana Hrudayalaya, Bangalore. First subtopic, factors affecting cardiac output, was done by Dr. Balaji Senthil, postgraduate, Mahatma Gandhi Medical College, Puducherry. Second subtopic, pharmacological inotropic support, was done by Dr. P.S.N. Raju, Chief Cardiac Anesthesiologist, Apollo Hospital, Vanagaram, Chennai. And third subtopic, mechanical circulatory support, was done by Dr. Subhendu Sarkar, Head of Cardiac Anesthesia, Dehradun Hospital and Heart Institute, Kolkata. And one more thing, we are going to conduct workshop on USG guided nerve blocks and CME on June 14th and 15th at Emigrant Hotel, Pudukkottai. I welcome all delegates to register and attend the CME. It will be very much useful to all postgraduates who are going to exams. I thank our academic chairman for his kind supports. Thank you all.
Thank you, Mr. Secretary. Now it is my duty to introduce the faculty to the audience. And today we are happy that all four are ladies. As I said, now they have shown the power, women power. And actually, after OG, anesthesia is the next specialty eroded by females, like a bulldozer. Then only pediatrics came, and now 80% will be ladies, I think, because the way in which the postgraduates join in anesthesiology, it is enthralling to see many women prefer anesthesiology. That's a good thing among the ladies. Now the youngest faculty of today is Dr. Rashmitha, who is going to talk about the neurogrid, which is essential to understand the mechanisms of labor pain relief. And she has done MBBS from Karnataka. So she knows Kannada as well as Telugu. And probably as she is in Hyderabad, she will know Urdu and Hindi also. So she is a multilinguistic lady doctor. She has done her MBBS from Bijapur, Karnataka, and she has done her MD in Karimnagar, Telangana. The Karimnagar, when I first traveled to this Nizamabad, I traveled via Karimnagar from Hyderabad to Nizamabad. So I still remember that. She has done her MD from Chalmeda Institute. And even with this young age, she has presented many research papers in the national conferences and state conferences, like ultrasound guided erector spinae block. That is a best thing. And see contra. Another one is CVP catheter mallocations. Then she has done IV magnesium sulfate and lab cholecystectomy. I don't know what she has done with that IV magnesium sulfate, so she will throw light upon that also. And the best part, the best introductory part for Dr. Rashmitha will be, everyone is interested. See, now Puthukkottai Bhudhan has become a matrimony. So this young doctor is waiting for a good match. So minimum 850 people will be listening. And madam is waiting for her proper match. So we wish her all the best and success in her future life also. And it will be followed by Dr. Shilpa, who is also looking like a postgraduate, but she is more intelligent than a postgraduate. And she has done a MD and a DIP-NB. DIP-NB is very difficult to clear. MD is very easy because it is institutionalized. And she has done a PDCC and a European diploma also. So the lot of knowledge, I don't know how they have time to do all these things. And she's a fellow in pediatric anesthesia. So even though she's interested in obstetric pain relief, she's a fellow in pediatric anesthesia, and she's a executive committee member in pediatric anesthesia chapter, and she's a trainer in PPLSS, and she's interested in OG, pediatric anesthesia, as well as transplant anesthesia. So even for delivery, she will anesthetize, and after delivery, she will anesthetize the newborn also. And with all these curricular activities, she is good at dancing, she is good at swimming, she is good at yoga. So she may be doing water yoga, we don't know. So with all these things, she is smiling. That is a great thing. So we thank Dr. Sailaja for bringing Dr. Shilpa into this webinar. And Dr. Sailaja is a consultant, senior consultant and a co-head. She is also a DIP-NB graduate. She is also a fellow in pediatric anesthesia. So she is a senior consultant and a co-head, and she is a WFSA committee member, DEA committee member. So that is a great thing, because now India is progressing in every aspect in WFSA. And madam is also means Shilpa is also a executive committee member, and she is also a executive committee member in pediatric anesthesia chapter. And more than that, she is a ACLS instructor. She is a editorial board member for JCR journal. And with all these things, she is interested in gardening. So now she is trying to grow some knowledge in our brain. So that is also a part of gardening. And she is interested in reading books. Not only these obstetric anesthesia books, she is interested in reading novels also. And she is interested in listening. Songs only, but now she is listening to, when we speak, she is also listening. So that should be appreciated. So we thank for that senior consultant to grace this occasion. And now imagine she is a WFSA DA committee member. She is a senior consultant at a Go Ahead. Such a great experience they have, vast experience they have in obstetric pain relief. So I don't know who can moderate these people, this three women power. So as it is obstetric chapter, see, immediate choice is the obstetric anesthesia president, Dr. Anju Grewal. See, you should all be happy. Last time, Dr. Muralidhar Kanchi has graced the occasion as a moderator. Now, Madam is president of the obstetric anesthesia chapter. In addition, she is a professor in All India Institute of Medical Sciences, Bathinda, Punjab. So imagine, to be a faculty in All India Institute of Medical Sciences itself is a very prestigious thing. And the madam is a president in that. And she is a president elect for RSACP also. So now she is the current president. So she is going to take over RSAPG also. And she's a former editor in JOACP journal. And madam is editor, peer reviewer for many journals. And in addition, she's an associate editor for Association of Regional Anesthesia magazine. And she has published, we cannot count, it is more than 100. And madam has authored 12 textbook chapters. In addition, she is the editor-in-chief for Anesthesia Tutorial of the Week, which is a prestigious publication from WFSA again. So, madam is a world head for that. And even then, madam has come for us just to, as a friendship and to educate the youngster. Madam, with a lot of prestigious achievements, has agreed to grace this occasion. And all these things are not enough to introduce her. She's a good human being. See, she is a president for so many societies. She is an editor for so many journals. But even then, her ailing, aged mother is being taken care of her. So that is the affection and the gratitude madam is showing to the mother, which should be an example for everyone. So with this introduction, I hand over the session to Dr. Anju Grewal, madam. Please, madam.
Thank you so much, Dr. Meenakshi, for such a gracious and warm welcome and introduction. I hope I'm audible to all of you.
Yes, ma'am.
Okay. So it is indeed a great privilege to be moderating this session today. It is an International Women Health Day today, and so it's pretty appropriate that we are talking about women health and we're talking about pain relief, one of the most important components of labor pain, how to relieve all and the various modalities available to us. And I have a very accomplished team, as Sir has introduced all of them. So without much ado, I would like to ask Dr. Rashmitha to start off. And before she starts, I would like to take this opportunity to exhort all viewers to join the Association of Obstetric Anesthesiologists India as members and strengthen the society so that we as Indians can also walk with pride in reducing the maternal mortality and morbidity across the country. So with these words, I would like to invite Dr. Rashmitha to talk to us about neurogrid of labor pain. She's a fellow of obstetric anesthesia, Birthright by Rainbow Hospitals, Hyderabad, Telangana. Over to you, Dr. Rashmitha.
Good evening, everyone. Myself, I'm Dr. Rashmitha. Currently, I'm doing fellowship in obstetric anesthesia at Rainbow Hospital, Hyderabad. So, So my topic for today is neurograde of labor pain. So pain, the word came from Latin that means punishment or penalty. International Association for Study of Pain defined as an unpleasant sensory and emotional experience associated with actual potential tissue damage or described in terms of such damage. The pain of childbirth is the most severe pain that women will endure in their lifetime. Women in pain don't need an indication for pain relief in labor. ASA, that is American Society of Anesthesiology, uh, in the absence of medical contraindication, maternal request for pain relief during labor is sufficient. Experience of labor is very complex and subjective. Several factors affect a woman's perception of labor, making experience unique. However, a consistent finding labor pain is marked a high on pain rating scale when compared to other painful life experiences. And just brief about the pain classification. Uh, uh, it is divided into acute pain and chronic pain. Acute pain is again divided into visceral pain and somatic pain. Somatic pain is again divided into superficial pain and deep somatic pain. In chronic pain, there is malignant pain and benign pain. Benign pain can be musculocutaneous or neuropathy. And on McGill Pain Questionnaire, it was rated as a most painful than a cancer pain. In Nalini Paris patients without prepared childbirth training, it was nearly as painful as amputation of a digit without an anesthesia. So this is a McGill's pain scale where we can see chronic pain syndromes and labor pain and pain after accidents. Nalini Paris with preparation have rated 30 on the scale of 50, and Nalini Paris no preparation have almost rated it as 40. So pain pathway. So experience of pain involves in transaction, transmission, modulation and pain perception. In the diagram, we can see all the four. So what is transduction? It is a process by which tissue damage stimuli activates the neural nerve endings. And in transmission, it refers to the relay function by which the message is carried from the site of the tissue injury to the brain regions underlying the perception. And what is modulation? Modulation is acting specifically to reduce the activity in the transmission system. And perception. So it is the perception received by the patient, but that is the experience of the pain. So mechanism of labor pain. So first stage, pain originates predominantly in the cervix and the lower uterine segments rather than the body of the uterus. So dilation of the cervix and lower uterine segment results in tissue distension, stretching and tearing. So these sensations are carried mainly by the C fibers. It is carried through inferior, middle, superior hypogastric plexus. We can see in the diagram itself. And from the hypogastric plexus, it travels with the sympathetic chain associated with the dorsal rami of T10 to L1 spinal nerves and referred as visceral pain. Repetitive contractions can initiate this release of mediators that may stimulate chemoreceptors. Such mediators include bradykinin, acetylcholine, serotonin, histamine, and potassium ions. In the addition to this mediators, prostaglandins, leukotrienes, and substance P and lactic acid may also serve as chemical nociceptive mediators to play a role in labor pain. And in the second stage of labor, it is a complete cervical dilatation until the delivery. The fetus descends into the birth canal and the progressively greater pressure on the fetus, on the vagina and perineum, which becomes additional source of pain. Distension of the birth canal causes intense stretching and tearing of the fascia and subcutaneous tissue and pressure on the skeletal muscles of the perineum. So somatic sensory impulses from the vagina and perineum are transmitted by the pudendal nerve to S2, S3 and S4 sacral segment. In this diagram, we can see the pudendal nerve via it is transmitting through S1, S2, S3 and S4. At the stage, patient experiences rectal pressure and urge to bear down as the presenting part descends into the pelvic outlet. At this stage, we hear most commonly from the patient that something is coming out. Central pathway. The pathway's labor sensation travels into the entire entry into the central nervous system, include both the ascending and the descending pathways. The ascending pathway, the first synapse in the pathways occurs in the dorsal gray matter of spinal cord, that is laminae 1 to 5. Most of the primary efferent neuron synapse initially in the more superficial lamina 1 and 2. Locally projecting interneurons in turn synapse on the more deeply located in the wide dynamic range, that is lamina 5 neurons. In wide dynamic range, neurons receive synaptic excitatory input for both the large myelinated A delta and A beta mechanoreceptors afferents and C polymodal nociceptive afferents. Here in the diagram we can see uh, projections from the dorsal gray matter crosses to the contralateral ventral side of the spinal cord and then cephalite via spinothalamic tract to the thalamus. From thalamus to a brainstem and cerebellum where spatial and temporal analysis occur. Then to the hypothalamic and limbic system where emotional and autonomic response originate. Descending pathway. So descending pathway, that is modulation, these pathways originate in the primary sensory cortex and project to periaqueductal gray matter in the midbrain, which further projects to the rostral ventral nuclei in the thalamus. This projection from the thalamus entered the spinal cord through dorsolateral funiculus and end in the dorsal gray matter of the spinal cord. Stages of labor. First stage, onset of true labor pains to the full cervical dilatation, and second stage, full cervical dilatation to the delivery of the baby, and the third stage, that is delivery of the placenta and the membranes. Fourth stage is the observation. Distribution of pain, labor pain, dermatomes. Pain in first stage of labor arises from the uterine contraction and cervical dilatation, and it is referred to the cutaneous branches T10 to L1 dermatomes. In pain in the second stage of labor is caused by distension of perineum and by the presenting part, stretching of the bladder, urethra, rectum, and it is referred to the lower lumbar and sacral segments, and this pain is carried by A delta and C fibers. Initially, the pain will be dull in the early stage of the labor, but later in the last stage of first stage of labor, and in the second stage of labor, the pain becomes very severe. And in this diagram, we can see the all the three colors, which is the mild, moderate, and the severe. Effect of pain on mother. So pain, it stimulates stress, obviously. So in stress, there'll be increased autonomic activity, and it increased autonomic activity leads to lipolysis, which increased fatty acids, then metabolic acidemia, and increased catecholamine release, which there'll be decrease in placental perfusion, which leads to fetal acidosis, and there will be impaired uterine contractions, and there will be increased gastrin release, and so there will be increased gastric activity, and due to stress there will be increased oxygen consumption, there will be hyperventilating, so there will be hyper respiratory alkalosis and hypocalcemia also, so there may be paresthesia and disorientation, and there can be ACTH secretion which releases cortisol release, and there will be increase in ADH release too. So the recent studies, there is a measurement for acute pain, that is BOLD and fMRI. That means BOLD is blood oxygen level, dependent functional magnetic resonance image, and FRMI means it is a functional neuroimaging techniques. These techniques are used recently in the recent studies to just see the level of pain in the brain activity. In fMRI maps local physiological or metabolic consequences of brain uh, by changing the blood flow. So there will be the oxygenation and it measures the oxygenation and deoxygenation level in the blood. So these are the recent studies in the labor pain. So thank you.
Thank you so much, Dr. Rashmitha, for an
Yes.
excellent elucidation of the entire neural pathways and the grid. And thank you for bringing out the latest studies that have looked at functional MRI and looked at mapped the brain to look at which areas do lit up with pain and how do they affect when there is good labor analgesia. We'll talk about it later on. We'll move to the second topic. And for that, I'll invite Dr. Shilpa to talk on labor pain relief. She's a consultant at Birthright by Rainbow Hospitals, Hyderabad, Telangana. Over to you, Dr. Shilpa.
Good evening, everyone. Myself, Shilpa, anesthetist, consultant anesthetist from the Birthright by Rainbow Hospital, Hyderabad. First of all, I would like to thank the ISA Puducherry City branch for giving me this opportunity. Sorry to intervene. I think, Rashmitha, you have to stop sharing, then only I can start sharing my screen.
Sorry, ma'am, just a minute. Uh, yes, ma'am, can you?
Yeah, yeah. Thank you, Rashmitha. I'll just share my screen in a minute. I think it's visible now.
Yes, ma'am.
Yeah. So the next 30 minutes, I'll just switch on the timer. I'm really sorry. Yeah. Next 30 minutes, I'll be speaking about the labor pain relief. So I already said I am from Birthright by Rainbow Hospital. About us, little bit about us. We provide labor analgesia services 24/7 in our hospital. It includes both pharmacological, non-pharmacological, everything, and also the neuraxial methods. Our aim is to give the painless normal delivery with the utmost safety. So in 30 minutes, what I'm really going to try to cover is non-pharmacological methods, pharmacological methods, neuraxial methods. In pharmacological methods, that is the new drug in the box, that is remifentanil. I'm going to highlight on that. And neuraxial analgesia, about the techniques and the drugs and how we maintain the labor analgesia with the neuraxial techniques. So first comes to the non-pharmacological options. There are many, like distractions, deviations, music, some herbs, some changes in the positions, and local applications of hot oil and massages, and some exercises and walking. There are acupuncture and TENS methods also. All these are all not effective very at pain relief. They're just distractions. So if you go into the history of labor analgesia to the 19th century, um, it was Queen Victoria received the chloroform for the birth of her eighth child, and she was very impressed by that, and she gave a positive remarks by the from that time it became very popular in that area. Then it was Reynolds inhaler for the chloroform. It was used. It is a nasal self-administration machine, and the another one is a Duke inhaler for trilene. Trilene is very short acting, and it causes a little bit of consciousness. One second. Challenge with all these methods are to maintain the sub-anesthetic doses but analgesic concentration. Mothers tend to become very sleepy over the time. So next I'll be covering about the Entonox. Entonox, all we know, is a 50% of oxygen with a 50% of laughing gas. And the picture which I have put explains most of it. It is very useful in the first stage of the labor, and it is taken self-administered by a demand valve or by a mask or by a mouthpiece. Side effects are nausea, vomiting, dizziness. This can be used as a bridging therapy until the patient takes the epidural, or if it can be given as an option to the patients which they are refusing to the epidural and there are contraindications for the neuraxial analgesia, the patient satisfaction is only 30% with the Entonox. And as the picture says, it is not very good for our environment, it destroys the ozone layer. So we have to be very careful because all our labor rooms will not have scavenging system. So it's better to be kept as a last option or last in the row. As much as possible, we'll take care of our environment. Then parenteral opioid analgesia, there are many. I will not go into the deep depth of everything. The one is which is very famous and still now in the remote areas used is the pethidine. It is given IV 50 and 100 micrograms. We know has a pethidine has a byproduct that is not pethidine. It has a side effects and it is long acting, and it has been shown also sedation in the mother, and there are newborn respiratory depressions and low APGAR scores with the pethidine. And fentanyl, I want to like to highlight here is it can be given as IV, IM, intranasal, even as a patient-controlled anesthesia or as a sister-controlled analgesia. The good part about the fentanyl is it has a lesser side effects and shorter acting, but it is not free of any side effects. It too has a side effect. It is not completely safe. And the next is the new drug in the box is remifentanil. It is supplied as remifentanil hydrochloride. It contains a glycine, which is alarming. It is only a IV medication, which we cannot use in the epidural and spinal. So I am talking about the parenteral opiates. So it is only a IV medication, cannot be used in the neuraxial thing. It is available as 1 mg and 2 mg. It has to be reconstituted. And the good part about remifentanil is it is short acting, rapid acting. Even after the hours of infusion, the complex sensitive half-life of the remifentanil remains between the 3 to 5 minutes. So it is good. So even if you give the remifentanil for 24-48 hours, the half-life remains the same. It actually readily crosses the placenta, but however, it get metabolized in the fetus. It is goes for the esterase based metabolism. So the alarming feature of remifentanil, what we have to be worried when you are using the remifentanil is a respiratory depression and the sedation in the mother. So always we have to make sure we watch the mother for the respiratory depression, apnea, saturation, and hypoventilation. And patient satisfaction is as good as epidural analgesia. And there are no differences in the APGAR scores with the PCA and neuraxial analgesia. Means APGAR scores is good, mother satisfaction is good. So the alarming feature is the respiratory depression and the sedation in the mother. So for that, we have to keep the safety measures like oxygen, naloxone, and neonatologist, and it has to be informed about the remifentanil use. So we have to be careful in the renal failure patients. The metabolite try to accumulate in the renal failure patients. This is how it is available as 1 mg and 2 mg vial. Okay. It's available in India now. We are using in our hospital. So there is this REMI PCA Safe Network. This is a registry where they till now there are 14,749 entries have done in this registry. This is a registry and this is a network to make sure to get a standard protocol for the REMI PCA and to monitor for the outcomes in the mother and baby. So according to this registry, till today, the side effects observed are hypoxia and sedation, which are like alarming, like 20 to 25%. Nausea and pruritus, nausea is also 16%. If you look at the maternal satisfaction, the dark green is completely satisfied and 45%, that is 34%, and 45% is also the mothers are fairly satisfied. So we, as I said, in our rainbow, we use this remifentanil. So what is our protocol is, so we keep the requirements for remifentanil, IV remifentanil is nasal prongs with oxygen and apparatus for the manual ventilation anytime they go for respiratory depression, SpO2 monitoring, continuous 1-to-1 nursing monitoring, dedicated IV cannula, and if possible ETCO2, so that we can pick up the respiratory depression earlier. So dedicated IV cannula, I want to highlight here, if you have a non-return valve, then you can use a normal cannula which you use for a IV fluid. If you don't have a non-return valve, it is better to have, it's not better, it is a must to have a dedicated IV cannula only for remifentanil. So how we constitute in our institute is we take 2 mg remifentanil mixed with the 50 ml saline, and so it will be 40 mics per ml with the dilution. The bolus we give is 40 mics over 10 seconds. It has to be given over 10 seconds, cannot be given fast. And lockout interval is 2 minutes, means between the boluses at least 2 minutes gap should be there. If these settings are not adequate, I mean the patient is not satisfied with analgesia with these settings, you can increase the bolus dose by 10 mcg regularly at the max of 80 mcg per dose. So as I said in the requirements, again, I want to highlight in the monitoring because they are prone for respiratory depression and sedation. So pulse ox, SpO2 monitoring, respiratory rate monitoring, and every 30 minutes blood pressure, pain scores, nausea, vomiting, and sedation scores has to be done. So first 3 to 4 boluses of remifentanil, anesthetist has to be around. Then the 1-to-1 nursing care has to be given, and naloxone ampoule has to be kept next to the patient, or which is handy, easily available. If there is a respiratory depression or apnea, when you say it, a respiratory rate less than 8 or oxygen saturation SpO2 less than 94% with oxygen mask, then you have to give a naloxone. Naloxone is available as 400 micrograms ampoule, which can be diluted to 10 ml. It will give 40 micrograms in 1 ml. So 40 micrograms increments every 30 seconds till the breathing improves, we can give the naloxone. The good pain relief, the patient, what I said in the previous slide, that it has a patient satisfaction as good as epidural, but the pain relief is always effective with the epidural. So this can be used as an alternative to the epidural analgesia when there are contraindications to the epidural, when the patient is refusing, or as a bridging therapy to the epidural when there is a waiting period for the epidural. So now come to the last part, which I'm going to take most of my time, about the neuraxial technique. So many methods are there: caudal, epidural, combined spinal epidural, dural puncture epidural, and spinal. So already my colleague has explained about the physiology and the anatomy, which is why the analgesia is very important. So I just want to highlight in this some points that why the labor epidural is a better option. It gives a sense of maternal autonomy and control, and decreased need of rescue analgesics, and higher incidence of spontaneous vaginal delivery, and effective pain relief in the first and second stage of labor, flexible, and it is responsive, simple delivery method with low maintenance for the staff, reduced risk of lower limb motor blockade, and it is safe. There are so many reasons to opt for labor analgesia, especially with the neuraxial technique. So this is a booklet what we have in our institute. So whoever comes with a labor pain like 1 to 2 centimeters dilated, so we give this information booklet to them so that they can go through the information booklet, and we personally go and counsel them and clear their doubts. Once they give consent, we will go ahead with the labor epidural or labor and neuraxial techniques. So I don't go into the complete step-by-step approach to a epidural. All of us know. So loss of resistance to air, saline, or a combination can be done. Usually we use at 18 case needles, and 19 to 20 case uni or we use a multi-port catheters. Usually the depth of insertion, I mean like the once catheter threading, 4 to 5 should be fine. If it is less than 4, there is high chances of epidural failure, and if it is more than 6 centimeters, there is a chances of catheter going into the one side, causing a unilateral block and venous cannulation. So once you have secured the epidural with the sterile precautions and all those things, then you have given a bolus dose and you have to assess the epidural block. So without assessing epidural block, you cannot say the patient is satisfied or it's working, not working and all. So you have to assess for the sensory level and for the motor block. In our institute, we use cold ice cubes, not ice cubes, that is a 10 ml saline, which is freezed like a ice cube. We use it to assess the sensory level. And I want to highlight something about a pre-procedural neuraxial ultrasound. We all know as an obstetric anesthetist, so the obstetric spine is very unexpected. There are many patients are coming with obesity nowadays, and many patients are with the spine surgeries, abnormal spines with the scoliosis. In our institute, we have a protocol. Whenever we see a abnormal spine and when we have a doubt, we mark with the ultrasound pre-procedure. Make sure that what is the depth and where is the midline and where we have to poke, and it needs experience and training. So I am not going into the depth of how to do the ultrasound. So what are the goals of a labor neuraxial neuraxial labor and neuraxial technique is, the patient should have pain relief bilaterally, and there should be a preservation of motor function, preservation of touch and pressure, maintenance of uteroplacental perfusion, minimal effect on the progress of labor and delivery, and you should avoid the complications like infection, headache, epidural hematoma, and nerve damage. So this is a busy slide. I'm not going into deep into this. So what I try to tell in this slide is, we have many techniques: plain epidural, dural punctual epidural, and combined spinal epidural. Combined spinal epidural is where you through the needle through needle technique, you poke the dura and give some drug in the intrathecal space, and then uh, put the catheter in the epidural space. That is combined spinal epidural. Whereas in the dural puncture epidural, you intentionally make a hole in the dura but don't give any injections there, and put a catheter in the epidural space. And the plain epidural is just plain epidural. A hole for better, lot better means, if you have a hole in the uh, dura, means the drug can seep into the intrathecal space. Because of that, the CSE and the dural puncture epidural, the analgesia onset is faster and the block quality is also faster. So we are making a hole, and that is better, we understood. But the thing is, we should not have side effects because of that also. And at what sizes of spinal needle we get the benefits and we get the side effects. Up to 25 to 26, we get best results like good sacral spread, reduced onset time, bilateral pain relief, reduction in the local anesthetic dose. But we have to think about increased chances of PDPH because we are going to poke the dura. So at 27, the benefits, all these benefits are very less. And so there is not much benefits with the smaller, bigger gauge needle. Means the smaller the thickness of the needle, that benefits are less. So we got to know about the techniques, what are the techniques are there, and we know the procedure. Then we got to know the which technique is better. Now we are going to the drug, how we are going to maintain the infusions. So if you give a low concentration of local anesthetic, that is better than a higher concentration of local anesthetic, as our aim is to maintain the motor block, at the meantime have a sensory block so that there is a pain relief. So if you give a lower concentration, what are the advantages? The difference in that, there is no difference in the maternal analgesia, whether you give a low concentration or a high concentration. And as you use a low concentration, there is a low dose of LA going into the patient. And there is a reduced duration of first stage and second stage of labor, reduced motor block, and increased incidence of spontaneous vaginal delivery, decreased incidence of instrumental and cesarean section, and there is no difference in the maternal satisfaction. Means with a low concentration, patient is happy, you are happy, and there is no motor block, and the obstetrician is also happy because increased chance of spontaneous and vaginal delivery and less chances of instrumental and cesarean section. So in this slide, it looks a busy slide, but I just try to explain everything. So for the maintenance, you can give as a continuous infusion of the drug, that is CEI. And the second one is PIEB, programmed intermittent epidural bolus. In this, the clinicians program the machine so that it gives a fixed dose. With fixed volume of the drug will be delivered to the patient at regular intervals. PCEA is patient controlled epidural analgesia. In this, patient presses when they feel the contractions, when they feel the pain, and the machine will deliver the drug. it means it also has a safety precautions, making sure not to deliver the uh, above the safe dose. It will not deliver above the safe dose. We program it like that. So there is the another option is called as continuous epidural infusion along with a PCE, patient controlled epidural analgesia. In this, there will be some low dose of drug will be continuously infusing in between. The patient will take the bolus whenever she feels the pains unbearable. The last one is PIEB with a PCEA, means programmed intermittent epidural bolus plus patient controlled epidural analgesia. Of all these techniques, the best patient safety and patient satisfaction is with the last one that has both the programmed intermittent epidural bolus, means the clinicians has programmed the machine to give the boluses intermittently at regular intervals. Along with that, patient can also opt for taking another bolus whenever she feels it is too severe to bear. So as I said with these techniques, I said it's always to go for the bolus is better than the infusion, because if you look at this picture, this is an epidural space, and if you give a continuous infusion, the drug tries to get accumulate in the one place, and the spread is very less. If you look at the intermittent bolus technique, with the bolus with the pressure, the drugs distribute very well in the epidural space. That is why the patient satisfaction is good. This is the PCA pump we have in our institute, which we use for the patients. Then spinal itself, it can be a single shot technique or it can be an infusion. So the spinal can be opted for low resource settings where you still want to give a labor analgesia to the patient. So if you want to give a single shot spinal, you can add additives which prolongs the local anesthetics like clonidine and morphine. But the disadvantage of this is it is a single shot. If the labor prolongs, you don't have any control over analgesia. If you have a catheter, you can give a low dose of local anesthetics as infusion, but you are putting a catheter, you are putting a needle through the dura. Usually if you are putting a catheter, the needle has to be big, and that kind of big puncture in the dura, the high chances of PDPH, that has to be kept in the mind. Other than that, we have to be vigilant for the high spinal and total spinal in these cases. So we spoke about the techniques, we spoke about how to do the maintenance, and now we are going for a drug, which is an ideal drug for an epidural. So any ideal has to have some of the features to say it is an ideal. It has to be rapid onset, minimal motor blockade, minimal risk for the maternal toxicity, and negligible effect on the uterine activity and the intraplacental perfusion, limited transplacental transfer, and it should have a long duration of action. Just with the local anesthetic, we cannot get an ideal drug. So combination of a local anesthetic with an opioid allows us to approach this goal. So what we regularly use in labor analgesia, the local anesthetics are bupivacaine, and lovenox. Bupivacaine is known for like decades, till from 1960s we are using it because it is highly protein bound, limits the transplacental transfer, and we can give at low concentrations and high volumes. Ropivacaine and levobupivacaine also can be used. The advantages of these compared to the bupivacaine is less cardiotoxicity and less motor block. If you look at the dosages in the epidural analgesia for the bupivacaine, we can go as low as 0.0625% to 0.8%. 0.08% is called as the ultra low concentration of epidural local anesthetic that has shown a good results. As I said in the previous slides, the low dose is better compared to the low concentration is better than the higher concentration. So as I said, LA with the opioids gives a better as good as an ideal drug. So why the opioids makes the local anesthetics together better is it has a synergistic effect with the LA. It reduces the dose of LA by 4 times. It has been shown that it increases the duration of analgesia, decreases the motor block, better maternal satisfaction, and better labor outcomes. We all know the side effects of opioids, that is pruritus, nausea, and vomiting. The regularly we use fentanyl. The epidural dosage is 1 to 3 mics per ml, and the intrathecal is 25 mics. So other than the non-opioids, many drugs have been tried and studied. We all know the clonidine and dexmet as very good additives to the neuraxial techniques on even for the peripheral nerve blocks. They are alpha 2 agonist, but we all know that side effects is sedation, hypertension, bradycardia, and all those things. Epinephrine also has been used. It has a vasoconstrictive effects, but it reduces the dose of bupivacaine, increases the chances of motor block, and possibly prolongation of labor. Neostigmine also has shown that good analgesic effect, but it has side effects like nausea and vomiting. Dexamethasone, midazolam, and ketamine magnesium sulfate, no sufficient data to tell them they are good. So in conclusions, I want to tell is go for ultra low concentrations of local anesthetic, which is the best, and add the opiates to it to accelerate it. And the technique maintenance is PIEB combined with the PCEA mode is the best. That is programmed intermittent epidural bolus with the patient controlled epidural analgesia. At the last and the most important, the last fundamental part of an optimal epidural maintenance regimen is the anesthetist. The take-home messages is the gold standard for the labor analgesia is consider epidural or combined spinal epidural. Always assess the epidural block. Go and see the patients in between, how they are doing, what they require, and always go for the high volume, low concentrations, intermittent boluses rather than infusions. Ultrasound should be considered in the difficult cases. Follow the regular protocol. This is the very important. If you don't have a regular protocol, it is safer. It is better to if you have a regular protocol, it is safer than doing an occasional labor epidural. Spinal should be considered in the low resource settings, and remifentanil whenever there is a contraindication, patient refusal, it is a wonderful drug to use it for a IV PCA pumps for the labor analgesia. But we have to be careful about the sedation and respiratory depression in the mother. Actually, the Remi-PCA is off-label use in the obstetric labor analgesia. So I give this slide to my patients. I explain about all the options and tell them to choose their favorite analgesia. Thank you.
Thank you so much, Dr. Shilpa, for such an elaborate talk. And you actually covered the very pertinent core messages for each aspect of pain relief. I think it's very well done. Excellent presentation, Dr. Shilpa. So from here, we'll move on to complications in labor pain relief. And we have Dr. Sailaja to talk to us. She's a senior consultant in Co-Head Care Hospital, Hitec, Hyderabad, Telangana. And we would actually love to hear from her not only what are the complications in various modalities, but also how to tackle them. Over to you, Dr. Shailaja.
Yeah, hello everyone. Am I audible?
Yes, ma'am, you're audible.
Yeah. So I thank Meenakshi sir for the kind introduction as well as giving me this opportunity here. So I'll be talking about the labor analgesia complications, which people have started asking about already in the chat box. So there is a saying by some person called Moyer: the delivery of the infant into the arms of a conscious and pain-free mother is one of the most exciting and rewarding moments in medicine. But I would say this is true when it is not associated with any complications. That is very important. So my objectives for this talk would be to review some of the common techniques for labor analgesia, to understand the complications and their causes, and discuss about the recognition and management of these complications, and highlight some of the strategies that can be used to prevent and improve the safety of the parturients. So these are all the techniques that Dr. Shilpa has wonderfully informed us about. I will be mostly dealing with epidural analgesia, which is the gold standard for analgesia in labor. And rest of it, I'll just breeze through. And so labor analgesia as such, if we see over the years, over the long years that it has been there with us, we have been practicing. So there have been a lot of issues with epidurals and a lot of problems that have actually may have put epidural in an obsolete way, but we progressed so much that we have adjusted all the drugs, we have used good technologies, and we have come up to such an extent that it can be comfortably used with care, and it can give proper pain relief to many, many parturients now. So what have we done that has changed the scenario? From it increasing cesarean section rates and it being considered to give long-term backaches and impacting the duration of labors or increasing the instrumental delivery rates. All these things were there previously, but now they have almost become obsolete because we have gained knowledge and we have improvised ourselves by using low-dose epidurals and by giving drugs in aliquots. And we have a remifentanil that has come into picture recently in India also. It has been a game changer. And newer local anesthetics have come up from the beginning, and a lot of adjuvants, as Dr. Shilpa spoke. So all these things have actually made the epidural better and safer. Also, there are technological advances that have been discussed, the ultrasound being one of the game changers, and there are novel drug delivery modalities that have been discussed. So all these changes that we have brought about in the management of labor epidurals and also the labor analgesia techniques overall has brought about a huge change in our practice, and that is why labor analgesia is practiced quite ubiquitously these days. So I'll be discussing about the complications of epidural analgesia under these headings. So coming to the technical complications, there are several of them. We'll go about one by one. So there can be a failed or partial block. So when does a failed or partial block occur? So when there is incorrect space identification. Usually this most of the times happens in obese patients where you feel a give way and go ahead and put the epidural catheter, and it is not actually in the space, and it is comfortably passed in between the loose fat globules in the tissues, subcutaneous and tissues of the back. So what can you do to prevent this? So whenever you are giving epidural for a obese patient, it is better to check with the ultrasound and mark it first, and then go ahead. You note the depth of it and just go ahead and push through the subcutaneous fat and all the other layers. And then when you reach the ligaments, that point, there is a stiffness. So when you move the needle, when you don't reach it, the needle moves quite freely. But when you reach the ligaments, then it is not very easy to move the needle up and down. So that is the time when you understand that you have actually reached beyond the fatty layers. And this is one way of deciding how overcoming the incorrect space identification. So there are inadequate local anesthetic spread issues also, which can cause partial blocks. It can be due to small injected volumes or septations or adhesions that are present in the epidural space. So what do you do then? How do you manage this? So whenever there is such issue, you can use a higher volume or a higher concentration, and you can adjust the catheter. So whenever you're placing the epidural catheter, you have a leeway of 1 to 2 centimeters, which you can utilize to withdraw a bit and then go ahead and give your dosage in aliquots and see if it is working. If it is not at all working properly, it is still a partial block, you can always ask the patient if you can redo from a different space, because the septations and adhesions will not be the same from all the spaces. We have done it several times and we have been successful the second time around too. And other things like catheter tip kinking, knotting, and lying against a vessel or ligament, all these things can also lead to partial blocks. So the thing I've told you about adjustment of the catheter can help here too. Then comes the high or total spinal block. See, whenever you have an accidental dural puncture that is unrecognized, there is a possibility of intrathecal injection of a full epidural dose. But when you give in aliquots, like when you give initially give 3 ml and then wait for a bit of response and then go ahead and top it up, then this is never going to happen, because if it is within the spinal space, the patient gets complete pain relief immediately. But if it is not, then only the tingling in the legs is there, and you will have to definitely top up to get a proper level. And excessive volume or concentration also is bad. That also can lead to total or high spinal. And injecting too large a bolus, as I told you, is a no-no, a big no, I would say. I always practice by giving aliquots only. And cranial spread. See, whenever patient positioning is in a Trendelenburg position, there is always a chance for the drug to spread cranially. Or if the CSF pressure is low, it can also draw up the anesthetic upwards. So we should always be mindful of all these things, even the patient position also. So somebody was asking about dural puncture. When we make a dural puncture, we advance the Tuhi needle through the dura. Then there is every chance of getting a post-dural puncture headache for the patient. So if the size of the needle is large, then the CSF leak is larger and post-dural puncture headache can be severe. So if you fail to recognize it and seal it, that is the time when it can get very bad for the patient. And mind you, the post-dural puncture headache is very severe, and we should actually, whenever a patient says headache, you should actually look into it and see if it is a post-dural puncture headache, or there are several other headaches that can happen also, like sinusitis headache, or that is one-sided, or meningitis that has fever associated, or seizures can happen, and PRES, that is posterior reversible encephalopathy syndrome. It also can have seizures more commonly, and it can be recognized by doing an MRI. So all the other headaches also have to be ruled out when you are looking at at a patient who is complaining of headache after a dural puncture also. So what are the symptoms of post-dural puncture headache? The headache is worsening when in sitting or standing position, and the patient is more comfortable when lying down. And it is overall, it is present all through the head, mostly kind of a dragging sensation in the occipital area and going back. And there is also neck stiffness, nausea, vomiting, and photophobia are also there associated with this kind of headache. So how do we go about treating it? First of all, how do we prevent it? I would say, whenever you encounter a dural puncture, kindly thread the catheter into the spinal space and use the catheter as a spinal catheter. Here you can reduce the dosage to 2 to 3 ml per hour and comfortably manage the patient, and the effect is very good. And if you keep the epidural catheter for around 24 hours, as the body's healing mechanism is already trying to surround the catheter and close the hole a bit. So whenever you remove the catheter, the hole is smaller and the chances of patient getting post-dural puncture headache are remote or lessened at least. And you can give, whenever you find that this is definitely a post-dural puncture headache, you should immediately start your treatment, pharmacological treatments. Like paracetamol can be used, NSAIDs can be used, you can utilize I'm sorry, I'm not getting it. The other caffeine can be used, and other medications like theophylline have also been used, but theophylline has a lesser therapeutic window. So there is possibility of it itself causing side effects. So it is not much utilized. And there are other modalities also. Sphenopalatine ganglion block is one of them. But the pain relief is instant, but quite temporary, I would say. So you put a lignocaine on a cotton-tipped stick and put it inside the nose near the pterygopalatine fossa and keep it there for around 10 minutes or so. It gives good pain relief. Yes, we have also tried it. But the patient comes back to you complaining of pain again. So this repetition and all is a little bit cumbersome. So this can be utilized when the patient doesn't want a epidural blood patch. It is not very easy for a patient to accept an epidural blood patch after hearing about how we go about it, because it is a process that's supposed to be done in a very sterile manner with two anesthetists at least, one drawing the blood from the antecubital fossa, around 20 ml blood is drawn, and in the back, in the lateral position, we go around the same space as we had given the epidural previously and inject this blood into the back of the patient. So this can sound a little bit scary to the patient, but we can explain that the blood itself clots normally, and that itself can seal the hole, and without using any external things, we can as such use the patient's own blood and seal the puncture. If we inform them in a gentle manner, they do agree to it, and we have done several epidural blood patches also in the long, almost 20 years practice. So next, going up to unilateral block. Epidural catheter tip position, if it lies off the midline, then one-sided spread can occur and unilateral block is a possibility. So here you can just adjust the catheter again and give a bolus. And in case of septations or midline gaps also, these actually preferentially go towards one side sometimes. So again, adjusting the catheter can help here too. And patient's position, if the patient is a position in a little bit of lateral tilt and feel patient sometime ask, I want to lie on the lateral side, I feel like turning to one side immediately. So please do not allow the patient to turn to one side immediately after giving the epidural. Tell them that you have to wait for some 10 to 15 minutes. Then after that, once you check the level and everything is good on both the sides, then is the time when you can allow the patient to turn on either side. So if at all you find a unilateral block, you can adjust the catheter and then turn the patient to the other side, side where the effect is not there, and then give a bolus. That usually sorts out this problem. Coming to catheter breakage, over advancement of or forceful removal are the issues that can cause catheter breakage. When catheter gets looped or knotted around other structures around, and if there's any manufacturing defect, a weak point over there on the catheter, and inadvertent shearing of the catheter by the Tuhi needle. Whenever you are not able to go forward, or you have a vascular placement, don't try to just pull out the catheter out of the Tuhi needle. Just pull out the catheter along with the Tuhi needle, because when you are trying to pull the catheter out with the Tuhi needle in place, there is every chance of it shearing and getting cut completely too sometimes. So this here you have to, whenever you remove the epidural catheter, you need to watch for the tip. If the tip is having the blue color that is given in the below pic, that means it has come out in toto. But if that is not present, that means a part of the catheter has remained within the back, which you will need to explain to the patient that the catheter is remaining in the back, but if it is not causing any trouble, it can be left alone over there. Many times it doesn't cause any trouble at all, but some very rarely it can cause trouble. That is when it will have to be removed. So catheter misplacements, like I was talking about intravascular placement, if that happens, then if you don't recognize it, then you give the whole of the dose, especially the bupivacaine, it can result in local anesthetic systemic toxicity. So we should be very careful whenever the procedure is done to see that intravascular placement is not there. When there is subdural placement, that is the tip dissects between the dura and arachnoid, then there is very unpredictable spread. The spread is patchy and high block can occur a lot of times in this. So whenever this happens, you need to tackle the hypotension that may happen with the high block immediately. So you should always have your rescue medications with you by the side before you start off doing the neuraxial procedure. That is imperative. And afterwards, you can just remove it and resite it elsewhere. Then intrathecal positioning. If it is unnoticed, full spinal effect can occur. You can prevent this if you are careful with your drug dosing. So how do we prevent any issues and the complications that we have talked about just now? Use low loss of resistance and test dose techniques meticulously and advance the catheter gently, monitor, aspirate for the backflow, and limit the injection volumes and titrate the doses. This is going to help you a lot. And recognize and manage the dural puncture promptly. Do not leave the patient and let them manage the headache by themselves. It is very important that we take care of the patient's headache as our own headache, because at our place we keep calling the patient on a daily basis and find out what is happening, and we keep adding other medications. Sumatriptan also can be added. We frequently keep adding it. It is a medication used for migraine, which can be useful for post-dural puncture headache also. And always aspirate before each bolus to rule out intravascular or subarachnoid placement, because even after a long time, the catheter can still migrate and go into intravascular or subarachnoid place. So coming to the pharmacological complications, there are several of them. We'll get into these things. So what are the reasons for drug errors? So look-alike, sound-alike drugs, we need to keep them labeled and color-coded, and usage of pre-filled color-coded syringes and large print labels, all these things tend to prevent the mistakes. And while calculating, we can make a mistake in the concentration when you're converting to volume or total mg, all those things, when the conversion's happening, then there is every chance to make a mistake. So we should be very careful with our calculations. And poor syringe or bag labeling in a fast-paced environment, that is seen very ubiquitously. We have seen in our own practice also that the sisters are so busy, they tend to forget to label the bag or the syringe. So this labeling and all should be at least monitored by us, and we should make sure that it happens so that issues don't occur, complications are reduced. And whenever handovers are happening, double checks should be done. Whoever is giving handover should give a proper handover about the drug, the concentration, the number of boluses given, when was the last bolus given, all these things should be properly handed over. And documentation also is important of these things so that overdosing and all doesn't happen. So there are several smart pumps also coming up with drug reduction, drug error, dose error reduction softwares also, which we can utilize. The human errors can be sorted out most of the times with these instruments with us. And education and protocols. Always we need to educate our people, our staff, to take care of the high-risk medications properly. And they should read back. Whenever my technician or nurse is giving me the drug, I'll always ask them to read out the drug name and also the expiry date and the concentration, everything they read out to me, and then only I recheck with my own eyes, and then only I take the drug. Allergic reactions are common with any of the drugs we use. So we should not be laid back, and we should have all the drugs necessary to tackle these reactions also, because some of the times they can get very out of hand. The anaphylactic reactions, if they are severe, it can lead to cardiac arrest also. So we should use preservative-free formulations whenever available. And because preservatives are more commonly known to cause allergic reactions, and any allergic history we should find out. And some patients, like I have seen in my entire career, 1 or 2 patients coming with allergies to multiple medications. So that is the time when skin testing, graded challenge, we had to refer them for. And yeah, as I told you before, always have the emergency medications ready. For anaphylaxis management, the epinephrine, steroids, antihistaminics, all these need to be at hand to save the patient. So opioid-induced side effects, already little bit has been talked about this. And the pruritus, nausea, vomiting, respiratory depression, all these things are quite common. The respiratory depression quite less so common, but the others we have seen quite a lot. So whenever we are giving doses, if we give fractionated doses, all the side effects, including the respiratory depression, come down by much. And we should have naloxone in hand all the time. So whenever there is a respiratory depression, we can use the naloxone and get away with it. Pruritus can be treated, and nausea vomiting can be treated by ondansetron or low-dose naloxone infusions. So complications are not just for the mother. There are fetal complications also. Neonatal respiratory depression can occur. Altered fetal heart rate patterns can happen. So all these things need to be considered, and opioid dosages should be titrated, and we should have a check on how much boluses we are giving. So coming to local anesthetic systemic toxicity, this is a very rare occurrence. I have not come across this so far, but we do keep 20% intralipid always stocked with us, so that in case of necessity, we are always ready to troubleshoot this. And this is mostly due to, as I said, intravascular injection or excessive total dose or rapid absorption from highly vascular regions, which is uncommon in our obstetric population, because we are going through the lumbar area, and impaired metabolism, hepatic disease, and hepatic disease, if it is there in parturients, and our PT-INR will be raised, and we would never be going ahead with a epidural as such. But yeah, local anesthetic systemic toxicity should still be kept in mind, and we can prevent it by, again, incremental dosing. And using a test dose is recommended for other kinds of epidurals, but not so effective for our patient population as an obstetric population, because of the pain itself, their heart rate rises. So this is a nice flow chart given by Nisora, which depicts how to go about treating last. It is always better to have it handy when we are treating it, so that we can go in a proper manner and treat the patient properly. So neurological complications, there are transient, persistent, and long-term issues also. Long-term issues are very, very rare. Transient neurological symptoms are mostly due to local anesthetic neurotoxicity, especially when it comes to lidocaine in the spinal space. This has been seen, and irritation of the nerve roots can happen. And sometimes we are unnecessarily blamed and our epidurals are unnecessarily blamed, because the transient neurological symptoms may probably be due to the patient positioning itself, hyperflexion or prolonged lithotomy. So you should always check whether that was done and inform the patient as well as the obstetrician and the nurses that this should not be done. So how do you tackle this? So avoid intrathecal lidocaine and use lesser neurotoxic agents, and use proper positioning of the patient. Reassure the patient that these are all transient and will go away. So keeping them comfortable mentally is very important. So when it comes to persistent motor or sensory deficit, that is a major issue. And this can happen when you have higher concentrations and volumes, higher volumes, and nerve trauma has happened directly with the needle or the catheter. So whenever you face a paresthesia when progressing the catheter, kindly don't proceed further. You try to twist the catheter a bit so that it is going away from the root of the nerve, and then go forward with it. So if there is any pre-existing neurological diseases also, you should document it beforehand so that there is specific proof that you haven't caused the motor or sensory deficit via the epidural, but it has been there from before. So prolonged compression or malpositioning or hematoma formation, all these things also can cause persistent motor or sensory deficits. So if at all the patient is complaining of severe deficits, you better go ahead with MRI of the back and find if there is any hematoma formed or any other issue that can be sorted immediately. So dilute solutions usage, correct needle and catheter placement, and not progressing when there are paresthesia, all these things will actually benefit us by not getting into this trouble. You can refer to the neurologist as and when required. So nerve injury, the reasons we already mentioned, the compression, the direct needle trauma, ischemia also sometimes due to the hypotension can cause nerve injury. So atraumatic techniques should be used, and immediate action should be taken if there is severe pain or paresthesia during needle insertion. Also, you stop and remove and redirect. So monitor the motor and sensory function after the procedure and document that there was paresthesia and what was done about it also, so that the other person knows what is happening if at all later the patient complains of these issues, and so that they can go forward and do the needful. And also maintain stable hemodynamics throughout the delivery process. So spinal hematoma or abscess is a possibility mostly when there is coagulopathy or anticoagulation, and inadequate aseptic precautions can lead to infections and abscess. So you should follow aseptic precautions properly and see that the patient doesn't have any coagulopathy or the anticoagulants. If they are on, you should follow strict guidelines and accordingly place your catheter when allowed. And indwelling catheters in immunocompromised or septic patients can also result in such kind of things. So it is better not to place when there is a systemic infection. And whenever backache or fever or neurological symptoms are complained, urgent MRI neurosurgical consultation is required. So obstetric specific considerations are also there. The hypotension, what I've been talking about, you should tackle it immediately by using ephedrine or mephentermine or phenylephrine. And fetal bradycardia. Sometimes fetal bradycardia happens when you give a combined spinal epidural especially. So mild fetal bradycardia initially can happen, which will revert back. Don't panic as soon as the obstetrician says there is fetal bradycardia after epidural. That is quite commonplace and that will settle usually. You should not allow hypotension or bradycardia to occur in the patient. That will sort the fetus out. Then prolonged second stage of labor is possible if you use too much of volume or too much of concentrations, and instrumental delivery also. So nowadays, as we use very low dose concentrations, these are all quite rare. Uterine hypertonia can occur when different drug interactions happen, like Synto and adrenaline together can cause it. So we should be mindful when we are giving medications. So how do we prevent all these things, all these complications? So checklists and protocols are the base of our practice when we can actually practice anywhere in our country, but still manage to have minimal or no complications. Ultrasound guidance for difficult epidurals will reduce the number of attempts and the complications therein, and also test dose use. I don't say test dose as such, I would say it as aliquots. And close monitoring, documentation, staff training, and simulation drills. These simulation drills we keep doing often, and this has helped us a lot in overcoming a lot of complications before they occur. So nitrous oxide is, that was all about epidural so far. This little bit about nitrous oxide. It has, yes, fast onset. It can be self-administered, and fetal safety is good, and maternal satisfaction is somewhat okay. I wouldn't say it's good, but for those who don't want to take epidural, that is a good option. But still, we need to think about our Mother Earth too. So there should be a scavenging system, which is lacking in many areas wherever it is used. And self-administration is a little cumbersome, and in the initial part of the labor, it is easier for them to do. But as the labor progresses, it is very difficult for the patient to do so. And occupational exposure to the surrounding staff and consultants, doctors, is always there. And if the labor intensity is much, it is of very limited efficacy. So there are some good recent studies on labor analgesia complications. Few of them I have picked up. There is EPIC trial in 2023. It compared epidural versus remifentanil, and the conclusion was that epidural is superior in pain relief, but there was no increase in major complications between the two procedures. So we can go ahead with either. When patient is not comfortable with epidural, we can go ahead with remifentanil, but we should have a 1:1 monitoring for that particular patient, because the side effects can happen quickly. And also, if it is not flowing properly, the patient will suddenly start having pain again. So there are SOAP guidelines that have been updated in 2022. They emphasize on low concentration local anesthetic and opioid combos. And they conclude that lower motor blockade and reduced instrumental delivery and fewer side effects happen when this is done. And US registry study has been done, wherever the epidurals and that are placed in a registry, and 120,000 parturients were analyzed, and complication rates were quite low. So please go ahead and give epidurals to the parturients who want it, because a pain-free birth is their birthright, I would say. And neuraxial hematoma review was done in meta-analysis across many countries, and the incidence is quite low when you adhere with the thromboprophylaxis. So it is very important to follow the guidelines. So I would end my talk with saying labor analgesia is generally very safe, but not risk-free. If you are vigilant, skillful, and proper teamwork is there, the complications are quite rare. And early recognition and management actually minimizes the morbidity and prevents the mortality, and continuous quality improvement at your own setups. That is very essential to keep the complications at bay. The bottom line is systematic approach to your patients and to your procedures. Thank you.
Thank you so much, Dr. Shailaja. It's been a very comprehensive talk. You have covered every aspect of complications, especially with the gold standard, the labor epidural. We'll now open the the session for questions, and I can see a few questions up there in the chat box.
Yes, ma'am.
Yeah. So one of the questions is, which technique is best, DP or conventional epidural, in bringing down the pain during second stage of labor? I believe that I haven't practiced DP as of now, but a conventional epidural, which is well placed, well tested, and is working well, functions very well during the second stage of labor. I'll pass on the question to Dr. Shilpa if she wants to add. Perhaps the
I just want to
audience wants
highlight
to know that if there is a request coming in the second stage of labor, what would you choose?
the first thing is first question I want to say is the DP at the conventional epidural for the second stage. The second stage of the labor where there is a delivery of the baby, it is already too late to take an epidural or a DPA. The patient will not be able to cooperate with the anesthetist. The procedure itself take 15 minutes. I don't think so we can give a DPE or a conventional epidural in the second stage by itself. And if you say it as a first stage of labor, which one you prefer? So if it is in the later stages like 4 or 5 centimeters where the contractions are very frequent and they want the onset of analgesia is very fast, then you can opt for a CSE. Otherwise, the conventional epidural is fine enough to go with the early stages of labor.
So what would you do, for a mother who is in second stage of labor and is, requesting now? She did not agree to you in the first stage, but now in the second stage, she really wants to get pain relief. So do we
The
have options for her?
spinal can be considered in that case. Quick single shot spinals can be considered, like including the clonidine or morphine with the smaller doses. We should be aware of the doses, side effects. Just not give the high dose. If you are versed with that, you can go with a small dose of a local anesthetic along with the these morphine or clonidine can be considered because it is a quick procedure. The single shot spinal compared to the classic epidural or a DP.
Okay, so one of the ways, I agree with you, but one of the ways to also handle it is perhaps do a CSE where you first put a spinal, right, and give pain relief. Put your small dose of local anesthetic or a opioid, and then wait for the mother to settle down, and then perhaps thread the catheter, because at times
Yes.
labor might get prolonged even, so we do not know whether your single short spinal might work in all cases.
I agree.
Yeah. Yeah, so that is one way to also tackle it. Of course, you look at
Madam,
your resources,
for the
very
madam,
important.
for the benefit of our audience, shall I ask one question to Dr. Shilpa?
Yes, yes, yes.
When exactly you select a DPE technique?
The DP is what the literature says is the DP is better than the classical epidural, just an epidural. In our institute, we are not regularly doing a DP.
Yeah, that is
Why?
what
Yeah,
madam.
we are not
Because we concentrate on postgraduates and youngsters. Routinely, we request the research papers. Mostly, it will confuse because the research papers are only for people like Dr. Anju Grewal. So we want to educate the youngsters. So if you say the mentality of youngsters is to pick up the uncommon things, they will in the exam if they ask, they will say immediately DPE. See, actually, after the advent of what I have seen with a little bit of our experience, that is even 20 years back, I have started doing it. See, with the advent of fentanyl, now remifentanil
Yeah.
has come. Once you add that narcotic, everything is fine with the single shot epidural, that is conventional epidural. So that is a good answer you have given. You are not practicing in your institute. That is what we want to say. Because the literature is different, theory is different. You give that take home message because you are having experience, volume of experience. Madam is also there. So just we are here to bridge the gap between the youngsters and the highly experienced people. Thank you. The next question is asked, someone has asked some question.
Yeah, there's another question where they have asked what to do if the dura is accidentally punctured. And I believe Dr. Shailaja has talked in depth about it. But one of the very important things that I want to emphasize here is as soon as you see that the CSF is pouring out, don't panic and pull out the needle. Just put the stillet inside and stay there and be calm. And now think, what can I do? Now, the mother is in pain. That won't, now you already have a dural hole. Put a small dose of your fentanyl up there. And then you can thread the catheter, as she very rightly pointed out. That catheter there would create a process of fibrosis around it, and then you can perhaps, take it out. But one thing that you have to remember, it's an intrathecal catheter, and not all centers would be as good as our faculty is. So we'll have issues of sepsis, meningitis, and drug errors. So you really need to knot them and manage them in most aseptic methods. Anything that you want to add, Dr.
Madam.
Shailaja?
Right.
Mhm.
Sailaja,
Sir,
ma'am?
you were saying, yeah. So yes, as rightly pointed by Dr. Anju Grewal, ma'am, we should be very particular about asepsis when a spinal catheter is there. Labeling also should be done properly, and information should go from point 1 to point 2 in an exact manner. Otherwise, this is going to get very dangerous for the patient. So whenever we have a spinal catheter in place, we label it that it is intrathecal. It is not supposed to be touched, or the volume, whatever is being given, has to be changed only by the anesthetist on duty. And the anesthetist on duty is perfectly informed that it is an intrathecal catheter and to be dealt with diligently. So all these informations, communication is a key in many of these complications. It can prevent many of these errors, human errors that happen. So that, I would say, is very, very imperative for all of you to follow.
Madam, this is a request to Dr. Anju Grewal, madam. Madam, as a president of Obstetric Anesthesiology Society, I request you to give it in the form of a press relief or write to Obstetric Society, because once, see, even your words say, once that CSF is pouring out, don't be panicky. But if you're staying quiet, the obstetrician is panicky. And she feels we say everything will be all right because we have punctured it. For her, it is a complication. So, in addition to educating the anesthesiologist, because you are in the post is vital actually. So, you write to them scientifically. I am writing it to you. You mentioned that because they think that you are safeguarding the anesthesiologist. Even how many times I have said the epidural catheter, even if it is left out, it need not produce anything, because in the text itself it is written, it should not be made as radio opaque because it will end up in unnecessary laminectomies. But even now, anesthetists are getting concerned that the bit is left out, and 3 or 4 years later, because of back pain, they sue the anesthesiologist. So I think people with your stature only can write. So you please write to the Obstetric Society president, requesting her to circulate it to all the obstetricians. That will be a vital service for anesthesiologists.
Sure, sir. We will do the needful. And what is very important, as sir has very rightly pointed out, and Dr. Shalja also pointed out, is the biggest analgesia is the way you talk to your mother empathetically. And that creates a kind of a bond where even if there are complications, they can be handled because you are communicating at every step. Just don't put the epidural and run off. That's important, to be there to monitor these pain reliefs. There's another question on remifentanil infusion being used. Where is it being used, and is it better? Can you take it, Dr. Shilpa or Dr. Shailaja? Because we don't use it in our center. We still do not have the availability of
Recently, it has
remifentanil.
come, madam. Remifentanil has recently come. And even now, people are finding it difficult to sell it because it needs the narcotic license. Yeah, so many questions are there because it is widely practiced.
Mhm.
So recently, as Sir mentioned, recently it has come. Even in our institute, it has recently come. We are also started with the study on a remifentanil infusion. So it is used as a something like a bridging therapy or failed epidural when the epidural is, you have put an epidural and it is not working, rather than poking the second and the third time and not sure of whether it is working in the second and third time. Give them the option of a remifentanil infusion. And the patients who are like, I don't want anything injection in the back, I'm really scared of my backache, anything options you want to give, then the remifentanil is a option. And the third one is any contraindications for the epidural, like any coagulopathy, or you are suspecting any infection in the back, or any scoliosis where it is practically technically challenging, then you can give an option of remifentanil to the patient. At the meantime, you have to explain the side effects and one-to-one nursing care, aware of the complications like sedation and respiratory depression is utmost important.
Absolutely. Very well said. There's another question, very controversial, I would say. Can't we put the epidural in a higher space so that the volume of local anesthetic would block the CSF leak? So I do not think the volume of local anesthetic can ever block the CSF leak. Rather, there's a big rent up there, and then that you actually creating a pathway for that to go in. I wouldn't recommend it. I would rather have an catheter up there into my rent up there so that I'm tackling that as well. Dr. Shailaja.
Absolutely, absolutely. Always put in the catheter, leave in the catheter there for 24 hours. That's the best practice you can do to take care of your patient, and whatever complication you've already caused, take care of that complication properly.
Absolutely. So with these words, I hand back the mic to Dr. Meenakshi. I also want to thank Dr. Rashmitha. She has done a very good talk initial, the
Yes.
base of our neural grid, I would say. And I would like to add that there are newer studies that have come up. Yeah, I just read because of this talk of hers that have looked at the mapping of the brain and looked at both when the epidural was given and when was not given. And what they have
Yes.
found is perhaps might, lead a way for newer therapeutic targets, especially on anterior cingulate cortex. But till the time they have proved that an epidural is, of course, gives better pain relief and is indeed useful for mothers. So
Yes.
that's, kind of a reaffirmation of carrying on learning these techniques safely and practicing them with all the standard operating procedures and having a quality check on them all the time. Thank you so much, Dr.
Thank
Meenakshi. We hand back the mic to you. Thank you, all the
Thank
speakers.
you very much, madam. I have learned two things now from this webinar. One, the ladies may delay anything, but once it is academics, they are doing it with military precision. 6:59, Dr. Shilpa finished, and 7:29, Dr. Sailaja finished. It is extremely good. It is extremely good because, however, may the great lecture, people will listen only for 1.5 hours. That is our motto, and you have done it commendably well. And I want to pass on one message to the youngsters. Dr. Anju Grewal madam is the president of the Obstetric Anaesthesia Society. She is the chief editor for this tutorial run by the World Federation of Societies of Anesthesiologists. But she humbly says, because of this webinar I read regarding neurological mapping, that keeps her growing, that helped her to reach this stature. So the youngsters don't say that we don't have enough time to do that. See, even for this, always be prepared. That is a motto of Scout and the anesthesiologist. So I salute all these four great ladies, and to follow them, our lady star from Pudukkottai ISA City branch, Dr. Hema, is going to propose the formal vote of thanks.
Thank you, sir. Good evening, all. Thank you for participating in today's episode on labor and pain relief. A sincere gratitude to our academic chairman, Dr. Meenakshi Sundaram, sir, the man behind the Pudukkottai webinar series. Thank you. Thank you, sir. I thank Dr. Rashmitha, fellow in obstetric anesthesia, Birthright by Rainbow Hospital, Hyderabad, on the topic on neurogrid on labor pain. I thank Dr. Shilpa, consultant, Birthright by Rainbow Hospital, Hyderabad, on the topic on labor pain and pain relief. I thank Dr. Sailaja Kambathulla, Senior Consultant and Co-Head Care Hospital, Hyderabad, on the topic on complications in labor pain relief, stressing on the importance of vigilance, skill, and teamwork in labor pain. Thank you, Madam. I thank our moderator, Dr. Anju Grewal, Professor and Head AIIMS, Bathinda, Punjab. We are honored to have you in our Pudukkottai webinar series. Thank you, Madam. Thank Clarinet for your continuous support. I thank you all for your continuous support for our webinar, and we expect the same enthusiasm and support in our upcoming webinar workshop on ultrasound guided blocks on June 14th and the CME program on the next day on June 15th, 2025. Thank you. Thank you all.